Okay, well, it's 8 o'clock. Thank you everyone for being here. We have the pleasure to have one of our own, Dr. Martin Brown, today to give us an update on inclusion body myositis. So thank you everyone for coming, and we're looking forward to the lecture. Thank you, Brown.
All right, good morning. Um, I'm Martin Brown. I'm talking about inclusion body myositis. There was recently a new classification scheme developed, um, um, and the diagnosis of IBM has kind of changed over the years. What is considered IBM and what is not considered IBM, and the epidemiology. The numbers for epidemiology varies widely because the definition of IBM is sometimes pathologic, it's sometimes clinical. And so there's been this effort to try and uh, better define what is considered inclusion body myositis. And we just had a patient a couple of weeks ago that I was going to use to to kind of start us off. First of all, my disclosures, I have a clinical trial for myasthenia gravis. Please, 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 if you find any patients who have generalized myasthenia gravis, if they're sick enough to get um, um, efgartigimod or something like that, they are sick enough to qualify for the trial. Unfortunately, if they're sick enough to get efgartigimod, they really don't want a chance at getting placebo. So we've had a hard time getting people enrolled. I don't have any conflict, a financial conflict of interest, but nothing that I tell you today, nothing, no treatment that I mentioned today is FDA approved. There's nothing approved for IBM. Every treatment's off label. And for that reason, I need to add this warning. I may disclose unlabeled or unapproved drugs, including IVIG and sirolimus, and whatever else it says there. I'll refer to the FDA approved package insert. So the objectives are twofold. Um, the first one's going to take a big chunk of our time, the clinical presentation and the diagnostic workup. So the patient that I saw with Azealia a couple of weeks ago was a 75-year-old guy. He's got a history of diabetes, some other things. He's had slowly progressive weakness that he first noticed in 2020. Then his daughter was with him. And after further questioning, it turns out that it's actually been going on for much longer than that. Um, his weakness involves things, grip, opening twist off lids, um, pinching the key to start his car. Um, and he's also had some falls. And one fall, he slid out of bed. It wasn't really a fall, but he couldn't get himself back up off the floor. He had to wait till his daughter got some help. Um, he began using a cane and then a walker. He also has had some dysphagia, worse with solids. Liquids are actually not a problem. Liquids, in fact, he needs liquids to swallow solids. So he needs to wash everything down with liquids. He was on a statin, but that's been stopped. And unfortunately, the weakness continued to very slowly progress. When you're seeing patients, this is like the best thing you can hear. As a neurologist, if you're getting a history, the patient says, that's a good question, you're on the right track. Now, if they say that to every question, it is not as rewarding, but if they say it, uh, so one question that I always ask pretty much any patient is if they have steps or stairs to get in or out of the house. Because if mobility is a problem, stairs are going to be an obstacle. And if stairs are an obstacle, if you're in the house and you smell gas or you hear a fire alarm, you need to be able to get out of the house quickly. And if you have steps that are going to get in your way, uh, that could be a problem. And also the questions that you ask can give you two pieces of information. One, how severe is this problem? And two, when did it start? Because some people will say, well, we had to move 5 years ago because I could no longer, or we had a ramp put in, or something like that. And when they tell you that, you want to know, well, when did you do that? Okay, so it's actually been going on for at least this long. Do you have trouble pinching a key to unlock your door or start a car? Is asking about upper extremity function. Do you have any trouble chewing or swallowing? You always want to ask where's liquids. You have more trouble with liquids or solids. Um, um, and then he had a walker, and nobody nobody likes this question, but people tend to remember when they first picked up a walker and when they first picked up a cane, and that can also help you with, well, he was walking without assistance until this year, and then he began walking with a cane, and then 3 years later the cane wasn't enough, and so you can track the progression and you can describe the severity that way, and it's actually makes for a good story. This is not his, another disclaimer, this is not my patient, but this is what it looks like. Ask him to turn his palms up. We're doing, we're doing pronator drift anyway. When after they're done, after you decided that they don't have any drift, ask them to make a fist, two fists, two tight fists. And if you make a tight fist, you can barely see your nails. Um, and in this patient, he tried to make a fist, and there was like this finger out and that finger out, and he couldn't bury his nails, and it was asymmetric like this. It might be one finger on one hand and a different finger on the other hand. Um, he was really weak. He was so weak that I was actually surprised that he was still ambulating. And that's another clue. When you see a patient and you think they're describing a moderate amount of weakness and you examine them and it's really a severe weakness, that also tells you that this has been going on for a long time and that it's been getting slowly worse, so slowly that they have had time to adapt. So you'll have patients that are going to describe how severe they're terrible, everything's terrible, and you do an exam and they're actually not that weak. These people are the opposite. You think, oh, well, this isn't going to be a bad exam. And if the patient is weaker than they think, it's probably been creeping up for years. He couldn't dorsiflex his ankles against gravity. He had pretty much weakness everywhere, multifocal weakness, not really a myotomal pattern, or it wasn't all proximal, it wasn't all distal, it wasn't symmetric. And then he had this atrophy that was really pronounced. You could see his femur, his right femur, um, and you can look at he had extra skin. You could see extra wrinkles here. So if you see wrinkles where a muscle used to be, there's probably atrophy. The muscle wasn't that small in the past. He also had some sensory loss, which was distal symmetric, kind of typical polyneuropathy pattern. He was areflexic throughout, and somehow we got him to stand up for a Romberg. And he was not steady on his feet. In 2020, his PCP saw that he had elevated liver enzymes. And so a hepatitis panel was done, right upper quadrant ultrasound. Fortunately, no liver biopsy was done because 3 years later, they finally checked the CK and that was elevated. And so the AST and the ALT, call them transaminases, and your brain will not get tricked into thinking these are liver enzymes. If you call them liver enzymes, you're going to think these are liver enzymes and you're going to stop paying attention. he had a neurodiagnostic study done outside, which I reviewed directly to make sure it was done properly, and it was. And he had a severe axonal polyneuropathy. And in multiple muscles, he had myopathic features, which is a totally different lecture. So with that presentation, we ordered a biopsy. We picked a muscle that was not so weak that that is just going to be degenerative, fatty tissue, fibrosis. You want to pick a muscle that is still got some strength. It's affected, but it's not so affected that it's like burned out. So we've ordered that, and we'll have to wait to see what the biopsy shows. So the European Neuro, I forget what ENMC stands for, but the new process for deciding what is IBM and what is not IBM is a two-step process. And the second step is always a biopsy. So to get the diagnosis of IBM, you basically need a biopsy. The first step before the biopsy is you decide, does this patient have a common presentation of IBM or an uncommon presentation of IBM? Because the workup might be more involved if they have an uncommon presentation, and it's less involved if they have a common presentation. And then the confirmatory investigations are done after you decide on the presentation. So the common presentation of IBM, age greater than 45. This used to be 50, and it wasn't sensitive enough. There were some people who were getting missed, and so the age has been lowered. Age greater than equal to or greater than 45. The weakness should have been going on for longer than 12 months. If someone comes to you and they had weakness that started last summer, it's not IBM, because the weakness of IBM is a disease that is just slightly worse than normal aging. So if no one knows what month their IBM started. Most people don't know what year their IBM started because it was so long ago and it crept up so slowly. There wasn't a discrete starting point. So all those three things. Oh, and then the CK should be less than 15 times the upper limit of normal. His was 2 or 3 times the upper limit of normal, and that is typical of IBM. So the common presentation, the pattern of weakness, involves the deep finger flexors and or the quadriceps. So the deep finger flexors curl this. They move the longest forearm flexors flex the most distal joint. So and the muscles that adduct that flex the thumb at this knuckle are intrinsics, and the ones that do the distal joint are more proximal. These are the ones that are affected. These are the ones that the thumb pinches that key to turn the doorknob to start the car. Both of these, the weakness of both of these areas is often symmetric, and it is often accompanied by dysphagia. But these two things are not the critical features. What's in blue are the critical features that tell you this is a common presentation of IBM. So in this study, there are 128 patients. You will see that IBM is about twice as common in men, so 2-to-1 ratio of males to females. The most common initial presentation, 58%, start with quadriceps weakness, and then finger flexor weakness and dysphagia are kind of tied for second. And you'll notice that in women, the dysphagia is more commonly an initial presentation. And we'll talk about, that will come back later. Now, the uncommon presentation of IBM, if they're less than 45 years old, if the weakness is less than 12 months, as far as they can recall, if the CK is more than 15 times upper limit of normal, or if the pattern of weakness, muscles involved are not the typical forearm flexors or knee extensors. So some people will develop axial weakness, head drop, or postural muscle weakness, dysphagia without anything else, just foot drop, facial diplegia, and a lot of proximal weakness is a little bit uncommon for IBM. So if they have this uncommon presentation, then we're going to have to do a little bit more of a diagnostic workup to make the diagnosis of IBM. If they have any of these, oh, uncommon presentation, yeah. So if they have this uncommon presentation, they'll need a little bit more of a workup. Now, if they have these features, family history of a neuromuscular disease, which they don't really clarify what is considered a neuromuscular disease because polyneuropathy is pretty common and that's a neuromuscular disease. But if there's a positive family history of a relevant neuromuscular disease or weakness, progressive weakness, if the IBM or if the EMG is inconsistent with IBM, like fasciculations, that's not myopathy, especially in the muscles of interest, the proximal muscles. If you have fasciculations distally, you could have that just from his neuropathy. But if it's all axonal loss, if it's all like neuropathy, then it's less likely to be from IBM. And then if they have any of these antibodies like JO1, SRP, TIF1 gamma, NX, whatever that one is, HMGCR, you should think of something else. That should kind of lead you down a different path. But he's actually on that path. So we're going to go straight to the biopsy, which is what we ordered when we saw him. So the gospel of IBM says endomesial lymphocytes surrounding non-necrotic muscle fibers with or without an invasion. This is to differentiate it from perifascicular atrophy, which is here's a fascicle, and the muscles in the center are fine, but the muscles on the rim around the outside of that fascicle. This is what we're looking at on the left is a close-up inside of a fascicle. But if you back up a little bit, you'll see that there are fascicles, and in dermatomyositis, you'll see this atrophy and around the perimeter. But this is endomesial, and then there are inflammatory cells invading these muscles, and we'll come to this later, but these are the rimmed vacuoles that we'll talk about. And talk about it right now. So this is a red rim vacuole. You can't really see the red until you zoom in a little bit, but there's a red rim around this. I forget what stain this is. And these are not found all the time, but and they actually can accumulate with age. You can, if you do a biopsy on someone who's very old, you can actually see some of these red rim vacuoles, but you shouldn't see as many as you see in an IBM muscle. And then the other feature is on the right, all of the muscles should be that light brown color, this tan, dark tan color. That's normal. Everything around it, all these other muscle fibers have decreased. This is cytochrome oxidase, and they should not have. The blue ones are stained for succinate dehydrogenase, and these two things, the COX and SDH, these are used to evaluate for mitochondrial abnormalities. Cytochrome oxidase is basically staining for complex 4 in the mitochondria, and succinate dehydrogenase is staining for complex 2 inside the mitochondria. And complex 2 is upregulated, or it staining increases in mitochondrial diseases or with mitochondrial dysfunction. The other supportive findings include this antibody called cytosolic 5' neonucleosidase 1A. And you can look it up. You can find references to CN1A from one lab, and it'll come back as NT5C1A in another lab. And if you have any questions, if you order anti-IBM antibodies, you'll get this every time. So a third name for the antibodies. So initially, this was first described in 2013, and it was really specific when it was first described. Since then, we found out that there are some other things that can have these antibodies, so it's a little less specific, but it's actually a little more sensitive. And then the imaging findings, there are some characteristic imaging findings on both MRI of muscle and on neuromuscular ultrasound. So these are from the same patient at 8 years, 18 years, and 25 years. This is the thigh, in case you weren't sure. This is the thigh, that's the femur, and anterior to the femur are the knee extensors, and posterior are the knee flexors. And the knee flexors are they're not too abnormal. Black is normal, or dark gray is normal. The vastus lateralis is not dark gray on either side, but the rectus femoris is. So this really unique pattern of this muscle being affected and that compartment not being affected, and even in this compartment, one muscle is spared and the other muscles are trashed. And it gradually spreads to involve the entire anterior compartment, and it starts to affect the hamstrings as well. But this is 25 years later, so. Yes, no. Yes, it is, and no, we don't. It is very peculiar. There's also a unique pattern in the foreleg. The medial rectus, for some reason, it can be totally wiped out, while the lateral, not rectus, sorry, medial gastrocnemius is really bad, and the lateral gastrocnemius is spared. And it can affect this FPL and not that FPL. So it's very peculiar in how it affects people, which is kind of why the clinical presentation is almost enough to make the diagnosis. I mean, this patient we saw has IBM. If the biopsy doesn't confirm it, it's because the biopsy was taken too proximal or too distal. The muscle, the other pattern is in the extensor compartment, it affects the distal muscle more severely, and the proximal muscle is better. So if you're absolutely running out of muscle to biopsy, ask the surgeon to get a proximal quadricep sample, because there might actually be some viable tissue in there. We have a patient who has IBM, but he doesn't have a biopsy confirmation because we got the muscle is too burned out. There was basically just degenerative fatty tissue. So the MRI and the ultrasound can sometimes help you decide what muscle to biopsy. We did not do that, but I'm still thinking about it. Getting an MRI to say, check this muscle at this level, because we don't want that muscle, and we don't want the muscle that's all burned out. So this is the forearm, elbows down here, and the wrists up here. And we're getting an ultrasound of the flexor compartment near the elbow. And this is a normal flexor compartment. This is the FCU, flexor carpi ulnaris. This is flexor digitorum profundus, these muscles. That's the nerve, ulnar nerve. And then this is the quadricep. And this right here is the bone. When ultrasound hits a bone, all of the sound waves are reflected back up to the probe. And so you have a bright rim on the surface of a bone and a shadow everywhere below the bone. So you can't do ultrasound through bone. But notice how much tissue is between. The skin is way up here, muscle is here, and there's the bone. And over here, muscle is like right up, almost touching the surface. And the muscle has, it's called increased echogenicity. Sort of think of like that ground glass pattern that you see in some people see in the chest CTs. Um, for some reason, the flexor carpi ulnaris in this patient is relatively spared, and these other muscles are just they're just totally echogenic, hyperechoic, and there's a loss of that normal architecture that you see. It should be black with little white stripes in it, and this is actually the USDA uses ultrasound to say this is USDA grade A beef. This is gristle. So this would not be good if you are into cannibalism. So this is lifted from a recent Continuum. I don't feel bad about lifting this from Continuum because they use BioRender. So AI generated this slide. So I don't feel like I'm, stealing intellectual property from anyone but a robot. Anyway, so here's your patient who presents with this progressive weakness. If they have a typical presentation, the age less than 45 or greater than 45, 12 months onset, CK. If they have that typical presentation and they have involvement of the deep finger flexor and the knee extensors, you can go straight to biopsy. If the biopsy has the mandatory finding, which is lymphocytes, endomysial lymphocytes, sometimes invading the non-necrotic muscle fibers. If you have that finding on a biopsy of this patient, you have a diagnosis of IBM. If you only have the deep flexor involvement or the knee extensor, then you need this mandatory finding, and you need one of these supportive criteria like the rim vacuoles or that NT5-C1A antibody or that typical appearance on ultrasound. If you have an atypical presentation, less than 45, higher CK, then you need this. You need to see this finding, and you need to see two of these supportive criteria. So there used to be probable and possible. It's now dichotomous. You have it or you don't. My patient who had a biopsy that was of basically fatty tissue, he has it is unconfirmed IBM, or I don't know what to call it yet. I haven't figured that out yet. But it's either you have it or you don't. The epidemiology, you will read that this is the most common acquired muscle disease in older adults. That's kind of vague, but that's kind of what it is. It seems like every rare disease has a higher incidence in Olmsted County, Minnesota, because that's where Mayo Clinic is. And I think people end up living near the Mayo Clinic when they have these rare diseases. But this is pretty high, an annual incidence of 0.32 to 1.22 per 100,000. The prevalence is still pretty low, and it varies by diagnostic criteria and also where the study was done. Turkey apparently has very little IBM, and Olmsted County has quite a bit of IBM. And it's among those age 30 or greater, or over 30, it's 10 to 13 per 100,000, and over 50, it goes up to 18 to 28 per 100,000. So this is an age-related disease. It is disabling, more disabling than it is life-limiting. Dysphagia is sometimes the initial symptom, and sometimes, most patients will eventually develop dysphagia. And of the patients who develop dysphagia, about half of them end up getting a G-tube. The first use of a cane is usually about 5 years after the weakness starts, and about 12 years. My patient, I'd say he's probably about 12 years into his disease because he is this close to needing a wheelchair. Uh, Also, about 50% of patients have some other autoimmune disease, Sjogren's or rheumatoid or something like that. And then it turns out that polyneuropathy is not that uncommon in IBM. Maybe it's because they're old and they have other things that cause polyneuropathy, but sometimes it is sort of suspected that polyneuropathy is part of inclusion body myositis. If you remember that the initial symptom in women, about 25% of the time, the initial symptom is dysphagia. And these are men, and in men, the survival is just slightly worse than normal aging. In women, uh, there's a separation at about 5 years. After they've had the disease for 5 years, there's a distinct uh, decrease in survival, and that continues. And that could be related to the dysphagia. Uh, just a few tidying up some things that I didn't know where else to put these, but the common presentation, the differential includes things like myotonic dystrophy. There are all these uh, things like anoctaminopathies and filamentopathies and dysferlinopathies, amyloid myopathy. And then there's something that is now called VCP disease. It used to be called IBM PFD, inclusion body myositis with early onset Paget's disease and frontotemporal dementia. And VCP disease is a lot easier to say. It's just named after the gene that is the protein that is mutated. Anyway, these can all present similarly to IBM. And it's often misdiagnosed. If you have progressive asymmetric painless weakness, first thing I'm going to think of is ALS. And so motor neuron disease is commonly in the differential for IBM, and I guess vice versa. Lumbar spinal stenosis, especially if the L3 or the L4 nerve roots are affected, you can have preferential weakness of the knee extensors. It can be asymmetric, like IBM. You can have walking intolerance. Polymyositis is obviously that's most of the reason that we need a biopsy is to decide, is this something that we're going to treat with steroids, or is it something else? And then dysphagia, if dysphagia has a really long list of possibilities, and dysphagia, even if it's worse with solids than liquids, there's still things like strictures and things like that. If you search, uh, if you go back and you look at old descriptions of IBM, you might not be looking at IBM. So the initial description that everyone refers to as of inclusion body myositis actually sounds more like something called hereditary inclusion body myopathy. And inclusion body myopathy is different from inclusion body myositis. And there's all kinds of other things that if you're going to look up IBM, just look in the past 5 years. Don't go back anywhere further than that. Well, yeah, some of them certainly. Like well, no, not necessarily. They just these were just things that had a weird presentation, myopathies that had a weird presentation. Um, But just if you're going to do a literature search, don't go back too far because it gets really murky if you go back. Okay, so that's the clinical presentation and the diagnostic workup, and now we're going to talk about the pathophysiology, which is really clear. Um, so, is inclusion body myositis a
Nice, please. Switched over to
myodegenerative
hoodies.
disease?
Is that okay?
Hello? Okay. What that was. Um, is inclusion body myositis a degenerative disease of muscle that ultimately eventually has inflammatory features, and the inflammatory cells are just there cleaning up the mess? Or is IBM a primary autoimmune disease which eventually shows features of myodegeneration? That is sort of the question. Before we go into that, you should know what some of these terms mean. Inclusion bodies are not seen on most muscle biopsies of patients who are diagnosed with inclusion body myositis. To see inclusion bodies, you need to do electron microscopy, and it's rarely done. So, but they are tubulofilamentous inclusions seen on electron microscopy. Autophagy or autophagy is literally, it means self-eating. This is normal. This is a normal mechanism of the cells will recycle things, they'll break things down, lysosomal degradation, and they'll reuse the ingredients to make new organelles or other structures. So this is normal, and it is one theory of IBM is that it's a defect in this cellular homeostasis mechanism. Rimmed vacuoles are vacuoles, autophagic vacuoles. And if you stain them, you can find inside there are a lot of nuclear membrane proteins. And so it's possible that this was a myonuclei that has degenerated, and this is the vacuole that's left over after a nucleus inside of a muscle is degenerated. Muscle cells, muscle fibers have a bunch of nuclei. It's not just one cell with one nuclei. It's one long fiber that has lots of nuclei inside of it. So you don't need all of them. So the evidence that IBM is a myodegenerative is actually pretty compelling. Like Alzheimer's disease, like Parkinson's disease, the incidence increases with age. Gradually, the longer you live, the better your chances are of getting Alzheimer, Parkinson, and IBM. So keep it up. It also is characterized by an accumulation of misfolded protein, ubiquitinated proteins, and all these protein aggregates. Things like TDP-43, you've heard of that before. You've heard of amyloid beta before. Phosphorylated tals. These accumulate inside the muscles of patients with IBM. You can actually use the same imaging that is used for diagnosing Alzheimer's. Take a picture of the brain, take a picture of the muscle, and you can pick up the same kind of pattern, amyloid deposition in muscles. And this aggregation, these misfolded ubiquitinated proteins, this is kind of considered a hallmark of neurodegenerative or myodegenerative diseases. Also, this could be the evidence for myodegenerative disease is that the mitochondrial pathology, the mitochondria, they accumulate these mutations, sort of somatic mutations. With age, the mitochondria start failing. They start to proliferate, and proliferate is not a good thing with mitochondria. It means that the last mitochondria is not working, so we're going to make more, but the new ones are really no better. So the accumulation of mitochondria is a bad thing. And that's what ragged red fibers are, and you can actually see ragged red fibers on the biopsy of some patients with IBM. And then the COX negative and the SDH positive fibers, that implies a mitochondrial dysfunction. And then last of all, IBM is a myodegenerative disease because steroids don't help. All the other immunosuppressants that have been tried don't help. IVIG doesn't help. So that is another argument that this is not an immune-mediated disease. We've already talked about that. And as a response to this accumulation of misfolded protein, that actually triggers the T cell inflammation. So that could be the reason that we see the T cells in this possibly myodegenerative disease. And this is like the worst graphic that I've ever seen. And I think that's probably why I ended up in this this journal that I've never heard of. But it's really horrible. I tried. It's not worth it. Don't waste your time. Again, 2015, don't go there. So is IBM actually an inflammatory disease that eventually acquires um, degenerative features? So evidence that IBM is an primarily inflammatory disease is these patients have that HLA haplotype that puts them at higher risk of developing autoimmune diseases. Also, a lot of these patients have positive ANA, Sjogren's, antibodies. There are also a ton of inflammatory cytokines, chemokines in IBM, patients with IBM. These antibodies, these NT5C1A antibodies, that kind of suggests an autoimmune component, and then the picture that we saw of a cell, inflammatory cell invading a muscle. That sounds inflammatory. So the HLA, these patients are more likely to have this ancestral haplotype that sort of increases their chances of things like myasthenia gravis, lupus, type 1 diabetes, things like that. So there's also this increase in these other antibodies like SSA and SSB are increased. ANA is more common, although that's not, that. Well, here's the control. So this is the normal population. ANA is actually not super uncommon, but it's more common in people with IBM, and this is less common in people without IBM and more common with IBM. So another point in favor of an inflammatory process. So muscle tissue, patients with IBM has this prominent interferon gamma driven process. There are increases in all these other inflammatory cytokines and chemokines. And there's actually been an attempt to make a diagnosis based on the pattern of which inflammatory cytokines and chemokines are expressed, because it's different in dermatomyositis and different in that immune-mediated necrotizing myopathy, that HMGCR. There's a different cytokine profile for those different conditions, and so these inflammatory markers also suggest that it's an inflammatory process. The antibodies suggest that there's an immune role of the immune system in the underlying the cause of this disease. So this is highly expressed in muscle, the cytosolic 5' nucleosidase. What it does is not as important as where it is. It's in muscle. And this antibody, it's not 100% specific, but it's pretty specific for inclusion body myositis. And that's what that says. And then, of course, there's the non-necrotic myofibers being invaded or surrounded by inflammatory, and they're T lymphocytes. If you stain just for lymphocytes, you won't see it, but these are T cells, not B cells. In fact, they're cytotoxic CD8 cells. And the muscles might actually be causing this damage to themselves. The muscles are they're like antigen presenting cells, and they're telling the T cells, come get me. If you stain for this MHC class 1 in normal muscle, you don't see a lot of staining, but if you stain for MHC class 1 on patients with IBM, you'll see pretty much every muscle fiber has this rim of class 1, MHC class 1 staining. And the CD8 cells, they express all these nasty things. And then also patients with IBM have fewer of what we call Tregs, Regulatory T cells are things that calm down the immune system, and these patients have a deficiency of those cells. Unfortunately, even though it seems like an inflammatory disease and it's called myositis, everything that has been tried so far has failed to change the outcome. There was a study, or maybe a couple studies, of IVIG in patients who had, well, they had IBM, and the only thing that seemed to respond was I think it's probably post hoc analysis. They said, well, the dysphagia got better in these people who had really bad dysphagia. But really, there's nothing has worked so far. There's just not been any response. And people who are on steroids, eventually they get worse faster. I think it's when the steroids are withdrawn. The steroids don't improve anything, and then when the steroids are withdrawn, they actually seem to decline worse than if they had never gotten steroids. So a more recent finding, well, not recent, but somewhat recent finding was that people with IBM have they're called T cell large granular lymphocytes. And these are cells which are terminally differentiated. And B cells and T cells are supposed to have these mechanisms that make them die. They're supposed to undergo apoptosis. And sometimes these cells lose the ability to die. And they're terminally differentiated. They're very specific in what they're going to attack. So you have these T cells that really like to attack muscle, and they don't know how to die. That's not a good combination. So immunosenescence is these cells are immunosenescent in this use of the term. They are terminally differentiated cells, primarily T cells, and they've lost the ability to proliferate, but they've also lost the ability to undergo apoptosis, and they're sort of stuck in being angry and too mean to die, and they're overstimulated. So they're kind of like really old physicians who just need to stop, but they keep going. Old burnt out T cells. You don't want those. And the most cytotoxic population of these cells express this thing called KLRG1. So when these cells were found, it was thought that we maybe had a treatment. So there was a treatment trial for ovipribart, which is a monoclonal antibody that attacks T cells that express this KLRG1 marker. And so they had 272 patients. There were two levels of dosing, and there was a placebo arm. And the primary endpoint was IBM-FRS is a modification of the ALS-FRS. It works pretty well. It's not perfect, but it works pretty well. It's used in these trials for IBM. And then there's some other endpoints. There shouldn't be a dot there, but dynamometry, grip dynamometry, and pinch dynamometry, and quadricep strength, quantifying those things with a dynamometer. Fortunately, this trial just last month, it turns out that it did not meet its primary endpoint. It was safe and well tolerated. There is an open label extension. Everyone who is in the trial has the opportunity to continue getting the drug because, you can't give up. So, but there it is another disappointment. Well, so this is from the company, and so they're always going to try and put a positive spin on things. The company released this statement to their shareholders who are now really upset. But there was this clinically meaningful slowing, meaning that we're not going to give up yet. And does anyone know what movie this is from? So you need to watch Galaxy Quest in the 90s, late 90s, before you were born. So this is kind of where we are right now, and this is sort of where I am right now. So IBM is kind of like ALS in slow motion. We can't stop it. It makes you weak. It's disabling, and eventually it probably is life-limiting. But so if you had a very slow form of ALS, and there, so Olviprubart is not available at your local pharmacy, but sirolimus is. So if there's a drug already on the market and there's a phase 3 trial going on, and these people, I didn't put the names, but the people who are running this trial, these are the legit IBM people. They make the rules of what's IBM and what's not IBM. So if there's a phase 3 trial of a drug that's already on the market and you have this disease, would you want to try exactly what they're getting in the trial? And so that's kind of what I would like to discuss. I would love to get some feedback on that because I'm seriously considering sirolimus is not expensive, and it's an interesting drug, and I don't have time to talk about how it works. But it's the next big thing. Hopefully not another dud, but if we try it, people can say, well, at least we tried, because right now we're not doing anything other than giving them walkers and wheelchairs. There is one effective treatment called exercise. The disease is a slowly progressive. It is just slightly faster decline than normal aging. And in normal aging, if you decide you're going to go to the gym, you can actually get stronger. Eventually, you'll kind of plateau and then you keep aging. If you have a disease that's just slightly worse than aging and you start exercising, you can actually strengthen. Some muscles are still going to be able to get stronger. The ones that are still black on the MRI, they're going to be able to get stronger. And so exercise is kind of like the only thing we can offer people with IBM. And so that's it. So a couple of questions for you. Can anyone tell me some biopsy findings that are not expected in inclusion body myositis? We can't do when I made questions for medical students, we weren't allowed to do these. I think they're called K questions or something like that. All of the following except. These are frowned upon, but I don't care. So all of the following except which of these are expected in IBM? Perivesicular distribution is not IBM. Perivesicular is that here's the fascicle, here's all the muscle fibers inside the fascicle. If the round atrophic muscle fibers are around the primary, they are perivesicular. That should make you think of dermatomyositis. So if you are going into pathology, don't get that wrong. All the other things are typical for IBM. Yes. Next. Which of the following are unexpected in the clinical presentation of inclusion body myositis? Does anyone know what genuflection is? Any Catholics in the audience or retired Catholics? Genuflection is So do you think someone with IBM is good? So I think that probably fits. Um, which one? How do you? Yeah. Okay, difficulty spraying PAM. Anything that involves this and this. This was actually the initial problem of one of my patients. She noticed that she could not use hairspray. There's another one. Fasciculations. So fasciculations, especially fasciculations sternocleidomastoid, that should make you think of motor neuron disease because that's a bulbar cranial innervated muscle mostly. But insidious onset of asymmetric weakness, knee extension. Oh, what else? What does this make you think of? Reduced recruitment. Where's Gentry? What does reduced recruitment mean? All polyphasic motor units. Unstable. Well, yeah, unstable motor units are either denervation or reinnervation. Reinnervation, you'll have tall, wide, polyphasic motor units. Myopathy, the motor units are short and thin, and neuropathy or reinnervation, tall, wide, polyphasic motor units. Actually, polyphasic could be neuropathic or myopathic, but tall motor units. And reduced recruitment is there are fewer axons getting to the muscle. Each axon is responsible for more of the muscle, so they get taller. And each axon is responsible for more of the muscle, and so you actually don't hear as many, you never get that full interference pattern. So reduced recruitment is a neuropathic clue. Everything else is steak or chicken breast, bagels, pizza crust. These are a problem. Okay, so here's a patient I saw last week. See the fingers? Make a fist. What's the diagnosis? Gotcha. So no, this lady has myotonic dystrophy. And myotonic dystrophy is a weird myopathy, more than a myopathy, but it tends to affect distal muscles, and the opposite of what you normally see with proximal symmetric weakness. She's got inability to do. She has a lot of the same problems. She can't do the ball. She had to change all the doorknobs, so not the ball doorknob to the lever doorknob, because she couldn't get out of her house. So, but if you see that picture and the quadriceps, and this is at 8 years after diagnosis, and here's 10 years after diagnosis, and that's pretty obvious. And then here's some of the muscle, some of the deep finger flexors are still working, and here they're almost all not working. So this is when we used to shake hands before COVID. This is the diagnosis. Along with myotonic dystrophy, there are two diseases that you can diagnose with a handshake. You shake hands with these people, and this is how they grip. They don't do this. They squeeze with the intrinsic hand muscles. They're doing all the grip. So that is it. Do you have any questions? Myopathic? Any muscular dystrophy? Some are diagnosed in childhood. Duchenne usually should be diagnosed in early childhood. Becker is sometimes diagnosed in childhood. Becker is sometimes diagnosed at age 70 in someone who went to the hospital, went to the emergency room, and they checked the CK, and it was high. And so Becker can be asymptomatic hyper-CKemia, and that's the only manifestation. And they die of something else at age 80. So Becker has a really broad spectrum of severity. And then all the limb-girdle muscular dystrophies. At IBM, it's called VCP disease now. Um, uh, there's not any. I don't know. I didn't look at that. If you can see TDP or amyloid or protein, I don't think that uh, that those are seen in dystrophinopathies. And the dystrophinopathies are one protein is malfunctioning, everything else is functioning normally, and and whether it's the immune system hitting multiple targets or whether it's degeneration of one thing that accumulates and the accumulation causes a cascade of events. Dystrophinopathies, it's a single protein that's defective and it has this classic pattern, typical pattern of, why things get worse. So I bet I'd have to look it up to see if any of those conditions have amyloid in the muscle. Yes, Rob? I will have to look that up. Um, um, I mean, in the same compartment, there's one muscle that is spared, and there's another muscle that. So yeah, you need these muscles to stand and walk on 2 feet. But I mean, these same muscles are in muscles that are, quadrupeds. But they're probably these are larger and those are smaller. But no, I'm not sure of that either. That's a good question. So there's the one antibody that attacks that cytosolic nucleosidase. If you, I mean, it is the muscles actually start to express MHC type 1. It's I didn't mention it, but IBM is actually more common in people who have had HIV for a long time. I don't know if anyone saw my patient with IBM. He has HIV. So proteins or viruses get inside of cells, and then new things are expressed. And then the cell might recognize that some of these new things don't belong here, and the cell will push it out to the surface and say, hey, come get it. That would be a T8 process. So whatever's inside of the muscle is being pushed out to the surface and saying, come get rid of this, or come and kill me because there's something going wrong inside of this cell. But as far as like what triggers, what is the ultimate target? I mean, it might not even be autoimmune. If you look at, I don't know what late stage Alzheimer's looks like, but I bet there are some inflammatory features that are not from, and in ALS, there's definitely inflammatory features of the motor neurons, but it's not an inflammatory disease. It's just that the immune system is sometimes part of the process of getting rid of things that have gone bad. I don't think CAR T has been tried. I'll have to look that up. I don't know if that has been, I didn't see that, but I didn't look for that specifically. But that's becoming a very hot topic in neuromuscular. There's a trial for myasthenia gravis using CAR T cell therapy. So I guess I need to learn about that. Yes. They're going to sign something. They're going to sign something that says, you know, there are risks in doing this, and it might not work, and it might cause trouble. And then with any patient, anytime I'm treating someone that I'm not sure if they actually have what I'm treating, like we have a lot of CIDP patients who are treated for CIDP and they actually don't have CIDP. And so I require them to go to a physical therapist periodically and show me that things are improving. Something has to improve for us to continue this treatment. If eventually everyone reaches a plateau, if it's a satisfactory plateau, then I'm going to start backing off of my intervention and wait for the decline to occur. And it has to be an objective decline that the physical therapist can measure to say, okay, you need it. You need the IVIG every 6 weeks, every 7 weeks, start to decline. So the problem is with this is that the trials have to be like 4 or 5 years long. Those are very expensive trials because how else are you going to differentiate? You saw that one slide of how slow it progresses. But it's just slightly worse than aging. So to separate from placebo takes a long time, and it's hard to invest in a trial that is going to take 5 years when it actually might fail. Um, so, and I even put a little post-it on here that says repeat the question, and I forgot to repeat the question, so I apologize to anyone who's on Zoom, anyone who's still on Zoom. I did not repeat the question. I don't see any questions online. You, Dominique, chat is okay. Any other questions? Okay.